I hope you're not expecting too much wisdom. I hope you're not expecting too much humor. I hope you're not expecting any studies to be quoted. You definitely will be disappointed if that's the case. First, thank you to everyone in the room. Before we get started, I wanted to share with Paul Skrzyński his award. He wasn't able to make it to graduation, but has served as our site director at St. Vincent and Now Memorial for almost a decade already, and has really done a terrific job.
Thank you, Jeff, because he was my mentor as St. Vincent. He was my mentor here. He came over to my house and had chicken dinner, I think. I was thinking about a job over at St. Vincent. The main person who got me over there. I really enjoyed my time there. I enjoyed my time here. So, thank you, Jeff.
Depending on how that goes, you almost feel like I'm being blamed. But
let me know what your next job starts.
I'll see out on it.
I don't go do shifts though.
A complete heartfelt thank you to everyone. I think that the residents in the room and the residents that have come before have been such a rewarding and wonderful group of people to work with. You should be very proud of the things that you do. And when I look out, and there are some teachers in the room who have been teaching for a long time in the back as well, there is not a single day in Worcester where over a 24-hour period there's not a UMass emergency medicine resident taking care of a patient in one of our emergency departments. So if you look at the schedule, there's always a graduate of this program serving patients in one of our ERs in the city. If you look at the different divisions that we have here in our department, there's not a single division that isn't staffed by a graduate of this program. And many of them that we've been able to just work with firsthand and work with directly. And that is something for the program to be proud of, and something for us to all be proud of together as we help build it together. I would be remiss in not thanking Christy and Martha Wright and Carrie O'Keefe. You are as good as your team, and that's where it starts, and that's where it ends. And without the effort of that team, you can't achieve anything. And with the right team, the sky's the limit. And if you're really slick, maybe you can reach the goals. If you really have the right team, you can have a lot of fun in the process. And I think with our residents, our residency, but with Carrie, Christy, and Martha, our site directors, it is not it's achieving goals. It's been just an awful loss. Today's a celebration, and we celebrate our time together that we had. Every day counts, every moment counts, and we look forward as well. Now, I also recognize that things don't always go perfectly. And I know maybe it's not what you're expecting to hear, but I assure you it is just as heartfelt. The things that don't go well are the things that shadow me, that I remember more closely, that I carry around a little bit. And I want to apologize for those things. No one is perfect, and we try, and we should try. But there are times where I am not as patient as I should be, or as understanding, insightful. There are times that we all, myself included, overreact or underreact. I know sometimes said, sometimes not said. I let some of you down on some occasions, and for those things, I'm truly sorry. And hope that the motivations and continuing effort together is what stands and what counts. So we have about 45 minutes together, and we can share some ideas. Part of it is medical, part of it is just other stuff. Part of it is just for fun, This is Bob Firm. I would point out a key aspect of Dr. Firm
Blurred back then.
that, oh, we've got this down, good, good. So if it was there once, it can return. So Dr. Firm, I leave that to you, your decision. But
Who is that?
we think it looked great,
Yeah.
and we think it is not a coincidence that your IBEX initials are Reaper. RFBR. So, cheers, and may you always have ibuprofen in your life.
Say it right,
Okay, so medical ideas for you. When you're doing LPs on kids, put them on a pulse ox and have a heating ammo bag available. You all know what bradycardia is in children, right? Bradycardia is hypoxia. And I have been impressed at how floppy and sweaty and gray children can get within 10 seconds of doing an LP. I will tell you, in the 16, 17 years that I've had the privilege of working with people like Barb Walsh and Mary O'Neill and all the other wonderful docs in the pediatric emergency department, Firm included, that's the only time I've ever done mouth to mouth on what's an infant who went from 160 to 90 to 40, as we realized, that, during an LP, and there was nothing set up. Take the parents out of the room. No matter, I'm a big fan of having people in the room for procedures or leaving it up to them, and this is my one exception. So no matter how much you try to explain it, it's brutal to see your child crunched up with a needle this big going through their back. I explained to them the importance of maintaining sterility, and this is the one procedure that I do have them step out of the room for. Every fiber of a parent is to protect their child. And it is the right instinct to want to take your kid, grab them away from the doctor, and run. It's not always it's not always a bad instinct to listen to, but this brings that out, and people won't tolerate it as well as they think. Get rid of them for LPs. Know that waiting is incredibly hard when they're separate. Promise them that as soon as the procedure is done, I will come get you. I will not forget. I know it's hard for you to be separate. When you say that, they get it. They trust you. They know that you get it. And then you make good on it. You walk out, you're still in your stock. You say, everything is good. You'll be able to come in about 30 seconds. They're just cleaning her up. But I wanted to let you know the procedure's over. And you'll just see them melt. You'll see the relief, and it's important. Procedures. This is a hospital cement floor. This is a head with a brain inside of it. Has anyone ever heard the sound of those two things meeting? This is a sound you will not soon forget. We have the data. Do not repeat the experiment. If somebody wants to stay in a room for a procedure, it is the law. They have to sit down. They think they're fine. They're not fine. Remember Donna over at St. Bede's? She pumped her up, right up for the bloody nose, turned, cracked, fell right over. But this is not uncommon. People think they're fine watching the procedure. They syncopize. You'll hear this sound once, and never do it again. Don't start a procedure until someone's actually sitting down. Codes. Are you okay bringing people in? I never was. Now I'm a huge fan. So my just quick advice on this is do it right. Know that what you're seeing is medical, what they're seeing is their family. If you went home right now and you saw someone you loved covered with blood or vomit, it would hurt you, right? You'd be stricken by that. So that's how it is for families when they come in and see this environment. So you got to do it right. You got to let the nurses and staff know that you're coming in before you come in, because things that are said professionally don't make sense to say in front of certain subject in front of families. You have to clean people up so they don't look bad. You have to assign someone to stand with that family member so they can explain what's going on while it's going on. children or adults. It's a big, I've talked with a lot of people who have lost families. There's no way around it. The emergency department is a place of tragedy. There's a lot of stories that unfold in front of you, and you will have contact with a lot of people that are getting tragedy and going through loss. But I've also had the benefit of seeing people afterward who do some teaching. People carry around guilt, and they carry around pain, and it hurts them. It affects their life. And you are in such a unique position to lighten that load a little bit. So I would encourage you to lighten. I would encourage you to let people know that people don't suffer, or they don't suffer. I would encourage you to let people know that it is true that coming in earlier wouldn't have mattered. Why should they spend the next 30 years wondering about that question? When it's not the right question, you can relieve them of that with a sentence with a doctor. At least the doctor said it didn't matter if you came in earlier. You have no idea the power of that sentence. People really struggle with not being able to say goodbye. You have the power to help them. This took me a long time to feel comfortable with. And I know this is heavy, and I'm sorry, the whole morning won't be heavy, but give people permission to say goodbye, to talk to their loved ones before you stop the code. I have been humbled at the impact. Because people, it's not their environment. They don't know what the rules are. What can they do, what can't they do? And when you say to them, it's okay for you to go and whisper in his ear that you're here and that you love him. And you don't underestimate how the impact of that later on when people got to say, well, at least I got to say goodbye and tell them that I love them. How many times have you heard, oh, my last conversation was a fight? You can take that away and say, you know what, we're not sure what people hear or not, but people can sense things. It's very different. When you stop a resuscitation, they're just as dead 2 seconds before you stop or 2 seconds after you stop. Boy, does it feel different. If you bring someone in and they whisper something like that in someone's ear when the resuscitation isn't active, it's not as healing. And that's something that you can do for people. They can touch, they can say goodbye, they can deliver a message. Think about it, try it, see how it works for you. You just do it the right way. The sparring pad here. These are the important things for you to know. That is actually Cromwell. And the other important thing for you to know, for those of you that work with Dr. Grazel while he was still here, working a day a week while he works as up to date as the editor, is that this was the only time in 4 years that he was cited without a fanny pack. And we have captured it on tape, and here it is.
And he never had hair.
It's important that that be shared with you. Okay, law should be just, but there's also the just law. You would never say the sentence, that's just a subdural, right? It's just an MI, it's just hypoglycemia. You know what, it's no big deal, it's just a brain tumor. It's just hypothyroid. But you may find yourself saying something like, they're just drunk. They're just difficult. They're just anxious. They're just annoying. So look at behavior as symptoms. Anytime you hear yourself saying just in your head, they're just this, they're just that, they're just difficult, they're just looking for drugs, that means you're not thinking. Because you see, life moves fast when you are, right? So you have to have these things which trigger a little bit that help. Oh, wait, this is a situation where I can run into trouble. I said, well, they're just. As soon as you hear yourself saying just, you're not thinking. Stop, slow down, retrain your words, retrain your approach. I know it's a little annoying sometimes when you all come to me and present a drug patient, and I stop you and say, no, they are a patient with altered mental status, possibly intoxicated. Because I don't want to miss hypoglycemia. I don't want to miss hypoxia. I don't want to miss head trauma. And I know I'm not perfect. And I know I'm at the same risk you are. And I know I think differently about an altered mental status patient than I think about a patient who's just drunk. So I need to think about that patient in a way that helps me to be a better doctor for them. Find the words, find the thing for yourself, but look out for just. Well, this is going back a little bit. This is Connie Nichols. This is Fran Renzi. This is Dr. Volcoro. Wasn't, you see, sometimes he had a smile and not only fully gray hair. Do you recognize this charming young man? Dr. Singh, you should step in front of the videotape for a moment.
Oh, I refuse to do that now.
It looks the exact same. Okay, the power of yes. So I want to help you with some patient confidence. And this is not trying to trick people. This is trying to collaborate with people. Somebody asks you a question and you say no. What are you in? You're in an argument. You're in a conflict. You want to go outside and smoke. How many of you say no to that? You're in an argument. You're in a conflict. I want to leave right now. Well, you really shouldn't leave, blah, blah, blah. Answer yes to start. And then you're not in an argument. And then you can partner with that patient. Because after yes, what comes? But. Can I go out and smoke? Absolutely. But before you do, I just need to listen to your love. Listen, I want to leave. I want to. Tonight, yeah, it's not prison. Definitely, it's okay. But before you do, we just check to see if you're lapsing. I would encourage you to not try to manage patients. I would encourage you to try to solve their problems. So when somebody wants to leave, it's usually because of time. I've been waiting for a CAT scan for 5 hours and I still haven't had it. To go in the room and explain the process is not as good as saying, you know what, that is frustrating. Let me get on the phone with them right now and see if we can fix it. You come back in and say, you know what, if you can hang out with us, we'll take you over an x-ray right now. I've never had a patient say, nah, forget about it. You know, if you solve the problem rather than manage the situation, it allows you to just move forward. But whatever people are asking you that's unreasonable up in the ER, start with yes, and then move on to what you need to do first, right? Because they don't understand what your priorities are. You know, they want something to drink. They want some pain medicine. They don't understand what you're worried about, what their priorities are. So yeah, absolutely, I can get that. I'm going to get that medication for you. Let me just get a little bit of information first to make sure that it's safe. Are you allergic? When did this start? So the power of yes. Now, as a backup, have any of you met them? They are very powerful. I use them all the time. The power of them. Well, I would like to be out of work for the next year. They don't let me do that. I'm sorry. Well, you know what? I don't understand why I can't have an MRI right now. They don't let us do that. And believe me, I'm just as upset about it as you. In fact, I have a meeting with them tomorrow to discuss exactly this issue because they're getting very frustrated. They don't let me do it. I'd like to do it. They just don't let me. They are very powerful. I work very closely with them. They have helped me through many conflicts over the years up in the emergency department. I ask that you can travel with them as well. When you're communicating with people, setting expectations can be really helpful. Now, again, it's not tricking them, it's communicating with them. I'm going to miss some things on x-ray. I love saying to people, listen, I flagged your x-ray, and the radiologist is going to take another look at it. And if they're seeing any little line that's not showing up well on our monitors, they're going to give you a call. Translation, I missed the fracture. Right? But the translation for them as well, this guy really cares. He flagged my x-ray. I'm going to get a special attention. Right? Every x-ray is flagged. Every x-ray gets overwritten. Listen, this is a high-risk wound. We do everything I can to help prevent infection. We're going to rinse it out. We're going to wash it. We're going to be really careful using special techniques. We're going to
put you on the antibiotics. There's still probably about a 15-20% chance that it gets infected. If this happens, I want you back right away. So I don't want this infection to get, that gets infected, no problem. That's what the doc told me, versus did bad job, that's why it got infected. Screaming Little Junior with the vermilion border laceration, right? I've told this to somebody individually. I tell them right up front, I want this to be perfect. When I put this stitch in, if you don't like how it looks, or I don't like how it looks, I'm going to take it out. I'm going to do it again. You really want this to be perfect for your kid. All right, so I put it in a stitch. I do a terrible job. It's all buckled. It's not even. I look at it and say, it's not perfect. Let's fix that. Clip, take it out. What's the parent think? Wow, a good, attentive doctor. What a perfectionist. He really cares about this. Our new interns aren't in the room right now, so it's okay to say, I use that sentence all the time with the new interns. Because when the stitch goes in, and they don't know that, you don't use silk on the face, and you walk in and you see someone, you can just clip it, no, you get it perfect, versus you don't have that conversation, you cut it and say, oh, you must be doing a bad job. So do the right thing for people, but let them know that you're going to do the right thing. It really helps with that relationship. Last thing on this is just power of being patient, power of being quiet. Wait for answers. You ask people questions. When you are in doubt, and it gets busy and you move fast, you are in doubt with the patient whether you should wait, listen a little longer, or move forward. Wait and listen. There's not a lot of time. Just explore. They may start talking, you realize, no, listen, I'm okay. I'm going to have to cut them off. I'm going to have to change direction, whatever. Not always. I would somewhat tragically share with you that almost every person who is admitted to me domestic abuse has been when I told myself to be quiet and to just wait another 2 seconds, 5 seconds, even though it's awkward, because I think there's something else that needs to be said. And often there is. And it makes you wonder how many times you didn't wait and how many times you missed by not waiting. Get comfortable with the awkwardness, allow for silence. It will be with you. If that doesn't work, you can always adopt Dr. Stuch's "You Gotta Be Kidding Me" look. This is a DMAT deployment of about 3,000 Boy Scouts during a rainstorm. Despite their marketing, let me reassure you, they are not prepared. Okay, quick 1 second. Hip pain with negative x-rays. What do you do? CAT scan. AAA with a negative CT who's symptomatic. What do you do? Vascular surgery. Dr. Manuel was someone who noticed that very early on and kind of put together a series. Negative CT, positive rupture in the operating room. Hypotensive, persistent pain. You get vascular involved even with a negative sepsis without a source. Antibiotic. Bad infectious disease? Maybe. Good emergency medicine? Yes. Sometimes there are different questions. Small hand lice. Explore. Dry fills. Good exposure. You will find tendon lacerations. Go through range of motions. Right? Body part through glass. What do you do? X-ray. X-ray. That's the rule. I don't know why or how, but you will find these chunks of glass hiding in people's scalps, hiding in their arms. It's amazing how much the fish can eat there. Grinding metal. X-ray. Yeah, metal on metal, high velocity. I want to make sure you can have a perfect visual acuity and have a small glow up. Got a feeling of foreign body in my eye. Is there a foreign body? Absolutely. Either that or corneal abrasion. I've never had a patient be wrong. Look harder. You'll find it. It's in there. There's either abrasion or there's a foreign body. Painful finger or toe. What do? Do a regional block. Meds before x-ray. Don't let them go off. I'm a big fan of medicating people before they get to x-ray for pain. If it's a finger or toe injury, do a bupivacaine block. helps you take care of them, they're more comfortable, you do better exams, helps your disposition because they're feeling better. You just do a good neuro exam. Good. Okay. Cognitive pauses. Stop and think. When do you stop and think? Well, you've got to build it into your thought process because otherwise you won't. You know, emergency medicine has become a sprint towards a disposition. And processing people is not the same as caring and thinking. The goal is to care and think. So you have to build in cognitive pauses with how you practice. For me, it's when I write a diagnosis. I don't think there's a single person in the room I haven't asked a question to when you've admitted a chest pain rule out. Okay, but if it's not ACS, what else could it be? Build those questions in where it works for you to kind of stop and say, does this make sense? Some people say, okay, every time I admit or discharge a patient, before I do that, I do a summary sentence. And then I say, all right, does my disposition match that sentence? If somebody read this sentence, would they be like, you got to be kidding me, you sent that person home? So build in that cognitive pause where you say, if it wasn't this, what else would you do? You'll find pulmonary embolisms when you do that. You'll find thoracic dissections. You'll observe people that do a discharge, and you'll be glad that you did. Okay, make time for fun, and when you combine fun with friends, and alcohol, you get Mary Elise, Manuel, and Bob and Karen in another lifetime ago. This was the Worcester Pub Crawl. Those of you who haven't participated in this athletic event, the rules are you run from pub to pub to pub, each team member, but before your next relay person can leave, the person arriving has to complete a drink. It's more disturbing how close 5 bars were together on this course. It was not a long run. And our team did place well. There's another one where Dr. Manuel is holding a trophy.
And Jeff, what are you holding in that picture, by the way?
Oh, that's an emphasis patient?
Yeah, okay.
No further questions. Dr. Karen always looked like this. Dr. Manuel always looked like she was 12. This is about 10 years. Over at St. Louis. Okay, agitated. Is that? No, I thought that was still Dr. Karen. Agitated patients. What is my advice to you? My advice to you is do not be part of the takedown team. Often people kind of jump into this, and I think there are times where patients are just very agitated, and it is a question of safety, and they just need to be physically restrained. And once they're physically restrained, you can move on to chemical sedation. You don't want people struggling against restraints for any length of time. There are times you can talk people down. You can engage. You're the doctor. You're the way out. And there are times that you can't. And you want to be careful of those times. Because you're the doctor, and because you can look for timing, I think it's important for you to not be part of the restraint. Because when this is going down and it happens, you walk over. When you start talking, why do you start talking? Because you're there to protect the patient. Because your training is medical. And you're a police officer. You look at some people as patients. Your training is also to look at people's threats as perpetrators, as criminals, right? It's a very different perspective. Some of our patients fall into that category. Very few do. Most of them are patients with agitation, delirium, intoxication, or something. So I will very routinely walk over and make public statements for the police. Not for the patient, because the patient isn't really engaged at this moment. Listen, you're in the hospital. No one's mad at you. You're not in any trouble. We just need to make sure that you're safe. Because you need to bring people back so they don't get carried away in the moment. Those statements are for the team. Now you've got control of the situation. You can walk over. They're yelling and screaming, whoa, I'm your doctor. You know, I understand all this. Well, that please, I'm your doctor. I'm just here to take care of you. I'm your doctor. You're the way out. Because there's a conflict, there's a lot of ego here, but you're the way out. You can make the problem go away. So if you walk over with that timing, I have found very common. They will be able to change focus on you, calm down, get a few other shouts in. Hopefully your security police have the frame of mind to just take those hits and not react to the verbal, last comments. And then they'll redirect. You can redirect people when they're agitated with simple commands. Okay, I just need to listen to your lungs. Just give me a second. I just need to listen to your lungs. See, that's what, it's part of the culture, right? That's what doctors do. They have stethoscopes. They listen to the lungs. Right? So when you do that with a very upset, agitated patient, so just let me listen to your lungs for a second. They comply, surprisingly so. And once someone now is listening to you, even on a simple command, there's a relationship, there's an engagement. And then you can build on that, and you can make it okay. Now, when you're when there's trouble, it's obvious that there's trouble. You don't always know that, and not to be paranoid. I think we work in a energetic environment, but it can sometimes be an unpredictable environment. Sometimes you can't talk people down, and it's when people are acutely intoxicated or drugs, the rules are different. The negotiation is different. You're not really talking with someone that can process the information. Sometimes it really is just a chemical restraint situation. Don't spend a lot of time. You don't want staff to get hurt. You don't want patients to get hurt. You don't want other patients that are sicker to get ignored. If you're going to give medicines, go ahead and give your medicines. Do your assessment. Move on. Watch people's hands. When I interview at EMH, when there's a patient who is altered, it's usually not sight. It's usually more alteration. When you're examining, no one's ever between you and the door in those situations. You can't fix everything. Sometimes it's okay to just walk away. Someone gets really upset and agitated. Our instinct is to calm, is to fix. Sometimes the right thing to do is just step out of the door, come back with help, and get the person taken care of. Sometimes examining, most people, the threat will come to you from hands. Every so often from someone's head or feet, but usually it's hands that will come to you. So I usually keep one eye on people's hands when I'm not sure how they're going to react or behave, so that if they start to move, I can just back out and get out of the way. The last thing they need is to end up in some conflict like that. It's the last thing I need to. If not, you call in your extra security team, Buzz Lightning and Charlie's Angels, and there's not a single security issue out there that this team cannot resolve.
I will always back you up.
You do, that's right. Don't mess with that kid. Okay, you get asked this question all the time. What are you going to do with those labs? Sometimes that's a good question, and you should think about it. Sometimes the answer is, I'm going to write those normal labs in the chart. That's what I'm going to do with those labs. I am not that sympathetic to the world's budget crisis when you are individually responsible for what happens to your patient, and you are individually liable for what happens to your patient. I'm not that interested in the system shifting the risk from the system to me as an individual. You want to lower the standard of care. You want to lower expectations. You want to have tort reform. No problem. I'm okay not getting those labs. Until then, what am I going to do with those labs? I'm going to look for them. They're going to be normal, and I'm going to write them on my darn chart. That's a little bit of an exaggeration, but only a little bit. So be conservative. Don't be too sympathetic to those things. Don't order things you don't need or that aren't useful. But when somebody asks you why you're getting a CPC on a 60-year-old who just doesn't feel like themselves, that's the answer. Don't check it. What are you going to do if it's abnormal? You're going to make a decision. You're going to say, I choose to ignore them. Or, wow, I'm really glad I found them. If you think the defense is, I just didn't care enough to look, then that's going to be a more powerful defense than, I didn't think that it was a problem, but I wanted to look into it, and this is why I dismissed the information. I'd rather go with number 2, because it shows an engagement, it shows the thought process, it shows a concern. Don't get DKG. What are you going to do if it's the right bundle? Well, you're going to think about it. You're going to talk to them. You're going to ask them. You're going to look for a moment. You're going to have them follow up. Or you're just going to say, I don't think there's anything to that. I'm going to ignore it. But you're going to be able to make a decision. So I'm a fan of looking and deciding. versus deciding not to look. Timestamps. Just some life liability advice to you all. Create timestamps, because every so often cases go bad in emergency medicine, and usually the timeline becomes really important. And having reviewed lots of cases over the years, it's harder to create a timeline than you might think. And 5 years from now, you don't really remember. See, when was that ultrasound ordered? Was it when you asked that the tech be paid? You hung up the phone from the tech but didn't write it on your chart? Or was it when they came in and the tech calls down to the secretary and says, oh, can you enter it into Meditech? Now 3 years later, where do you put, what's the timestamp? Well, it got printed from the Meditech records. That's when the ultrasound was ordered. That's not when the ultrasound was ordered. So when you have a high-risk situation, my suggestion to you is create your own timestamp just to show that you're on it. You know, when that patient comes in the door and it's a dangerous chief complaint on IBEX, click on as quick as I can. Because when someone prints that record, I want there to be the record. The patient showed up at 12 o'clock, jcukor was in the room at 12:02. Then you got to go in the room. But let's be honest, it does keep genuine. But my worry for you sometimes is that you do these things, but there's no record of it. And then people say it didn't happen because you didn't document it. That's not true. It happened because it happened, and I told you it happened. That's not how the whole world looks at it. You didn't write it, it wasn't true. Oddly, if you write it, people think it's true, whether it's fantasy or not, which is a little bizarre. But so create your own timestamps. Just click on quickly, get the orders entered time when you think it's going to happen. So hang around bar walls as much as you can, because eventually it will get you to Fenway Park. And if you're really lucky, it will get you to Fenway Park to watch a soccer game, which has happened like twice in history. And those are the two best days that exist in history.
And we had the best seats.
Yes, we did.
Is there anybody else there?
Was anyone else there?
Who said that?
Actually, there were a handful of Irish and English guys behind us watching as well. So, okay. If you